Hi, Roy here. After recording this episode, I had a huge relapse. To be honest, I thought about giving up. I thought about archiving this podcast and never recording again. I thought it will be too much for me, but I overcame. I think that I'm ready to go back to podcasting. I hope you enjoy this wonderful episode with Dr. Hector and that you keep on listening. Revolution from your bed. We have a special episode today. We have Dr. Hector all the way from Miami. And I'm super excited because Dr. Hector is engaging in my kind of lived experience topic, which is trauma, as I suffer from complex PTSD. I'm so happy to have you here, Doctor, and I would love you to introduce yourself.
Well, thank you for having me. I'm Dr. Hector, and I'm an integrative psychiatrist. Basically, it means that I work with both, looking at what most psychiatrists tend to look at, but I go a lot deeper. So it's like mixing Eastern with Western world modalities. Many people hear the word psychiatrist, they kind of run away because of the stigma, I think. We think, oh, I'm going to see a psychiatrist if I'm crazy. That's the most common thing I hear. And it's like, well, no, you got to think of the psychiatrist as someone who is the expert on your brain. And the brain does a lot of things. It also records a lot of things. And that's where trauma comes in. So I tend to introduce myself that way because I think most of us view the word psychiatry even as straitjackets and put away forever, right? Because it's what has been depicted in movies and TV shows, which is definitely not what is happening today, and much less what I do.
Absolutely. And there has been an interesting research. If I find it, I will link it. I don't remember
Hmm.
what was the name of the researcher about how TV shows creates different kind of vibe or
Hmm.
prestige around different medical specialties. And I think psychiatry was way down there alongside coroners, yeah, and
Yeah, the
radiologists and so on.
morgue,
Yeah, the more
the pathologist.
pathologist. Yeah. So I think we have a lot of work to do. And
Hmm. Hmm.
um, I wanted to ask you, what does it mean to integrate in psychiatry? What are you integrating?
So what I tend to do is, when we think of a psychiatrist, it's usually people that do just medicine, right? Pharmaceuticals, right? Medications, prescriptions, all that. But when I integrate things, I'm doing other modalities that maybe a therapist might do. I try to get even a lot deeper. I have a master's in theology, so I pay so much attention to the spirit and the soul of the person, which is what drew me a very interesting way to the real meaning of the word psychiatry. Psyche is actually well, it comes from the Greek mythology, and it's a statue of Cupid kissing a girl, and that girl, her name is Psyche. She's also known as the white butterfly, which is why I named my practice the white butterfly. I named it after her.
Mhm.
So psyche means soul, and then the word psychiatry means the medical treatment of the soul. So I think that's the part that I'm trying to integrate and kind of bring back to what is the root of this word and what are we doing, what we're doing today in mental health. And by shedding some light into what that means, I hope that's my evil plan. I hope that mental health space just changes and we psychiatrists or any mental health care clinician dives deeper into their interaction with the person that is in front of them, right? The person that we're working with, the patient. So that's what I try to do when I'm talking about integrating, what we know as traditional medicine. I'm an MD. I went to medical school. I went to residency here in the States for psychiatry, but I'm trying to bring back the real meaning of the word psychiatry.
Well, thank you. I think we really need more of that because the stigma is huge. Even,
Hmm.
I'm from Israel, but I live in Austria. I live in
Hmm.
Vienna, and this is the birthplace of modern psychology. But
Hmm.
even here, I can see the stigma around mental health. It's not as bad as in Israel. In Israel,
Hmm. Hmm.
before 7th of October, you could not even say PTSD. Like
Hmm.
you would have been kind of ostrated. But I feel that everywhere I go, the psychiatrists are complaining about the stigma and
Hmm.
that sometimes patients are kind of not in a hurry to come and see a psychiatrist, even though they need one.
Yeah. Yeah, the stigma is definitely very much there. And I think it's very much there, and I see it more in my international patients. I'm Cuban, I'm Hispanic, and in my Hispanic population, it's just the same. They'll go see anyone else where I'm like, well, that's this and that's this, and it's like perfect sense to me as a psychiatrist. The what they've been dealing with and holding back, and I think what the stigma ultimately does, it keeps people from getting better faster because it keeps them stuck, right? It keeps them stuck in their trauma, keeps them stuck in actually improving what they've been feeling. And the stigma is pretty strong. I think, in the US, it's gotten a lot better in the last maybe 2 or 3 decades, but it's still very present, especially in male patients. I
Mm.
see it more in those patients than I do in the female. And again, I see patients from everywhere. I've been really blessed to have worked with Daniel Amen Clinics, and that brought me patients. I mean, I have patients in Dubai, I have patients in Mexico, Colombia. I always work in collaboration with their team over there. So I work kind of like as a consultant in those cases. Um, but I totally see it in how they finally get to a psychiatrist, um, which is, it's sad because then by the time they come to me, they're doing so bad that I have to first stabilize and then go into the root causes, which is what I care for the most.
Oh, like for me, it's really connected to the state of being chronically ill because I
Hmm.
believe that anybody that has chronic illness has a mental health component to it. But most people that I talk to are not seeing it in this way. They say, I will go to see a mental health professional when I have mental health issues. But
Right.
the isolation, depression, gaslighting is not kind of accounted for. And
Hmm.
you mentioned care teams. How do you see the role of kind of the optimal role of a psychiatrist within a care team?
The way that I'm doing it. I meet with all of them. If I have a patient, like right now it comes to mind one of my patients with he has very severe pains from a really bad accident he had several years ago. Well, I need to meet with their pain management doctor. I need to meet with his endocrinologist because his hormones are out of whack because of the trauma to his brain. So, like, that's the way I see it. I used to be a fashion photographer, and I remember every time we would put together a photo shoot, we'll spend countless hours in meetings preparing for that photo shoot that was going to take place in 9 months or 10 months from that day. So I just try to copy and paste. So like what I did there is what I'm doing now. I tell people,
Mm,
well, if back then I was putting together a photo, today I'm putting together someone's life. I have to meet
mm,
with all those clinicians. And in those cases, I kind of act as the director. I tell people it's like the director of the movie. You need all the hundreds of people to work together to produce this thing at the end because the brain taps into every single organ system. So if I have the endocrinologist trying to figure out what's happening to their hormones, and I'm like, well, look at his brain, his
mm.
thalamus is overworked. So
Yeah,
going down the chain, you're going to get a bunch
yeah.
of endocrine, symptoms. So working in collaboration is one of the things that I do the most in my practice to make sure that we're all working towards the same goal. And what I've seen is that people get better way faster than they were before, just because we're meeting and we're working towards the same goals. So that's where I see medicine, um, and it needs to go back to that. I think at one point that was the case, but it's kind of deviated from it.
Yeah, I think that case management is something that is truly missing
Hmm.
um, in our landscape, and every healthcare system is designed in a different way, of course.
Hmm.
But in the U.S., actually, there is something that I really like because you have advanced practitioners, you have nurse practitioners and physician
Hmm.
assistants. You kind of have more um, outreach than in some other countries that you only have a psychiatrist. Like you have African countries that you have 5 psychiatrists in the entire country. Like I read a report and I was completely shocked. Do you work with some of those advanced role in your clinic?
In my clinic, no. In my clinic, all I have is psychiatrists. And in the past, but I worked with them whenever I'm in collaboration with any patient, depending on who the patient is working with. But it's, I think it has a lot of benefits because it can get to more people and have more care, because there's just so many psychiatrists in the first place. But one thing I think a lot of them are lacking is more education when it comes to the actual psychopharmacology of how these medications,
Mm,
for example, interact with each other. So I always tell patients, listen, I know that this clinician has knowledge in this area, but they're missing this whole other picture over
mm,
here just because they don't have the many years of education, because there is a difference, and you do see it. Sometimes it's in the fine tuning of certain treatments that they don't have it, but that's what working in collaboration does, right? It also helps them learn, and vice versa, right? I can get a bigger the rest of the picture from the patient when the other clinician is present. So it really depends on a case by case if the patient has that type of clinician. But I always tell my patient, listen, at the end of the day, the more brains involved in your care, the easier it's going to be.
yeah.
But it, it depends on, again, our knowledge of what's going on, and help. You want to guide the patient in teaching them what's going on, but at the same time, you need to really understand what is going on, but also what could happen
Mm,
in 6 or 9 months down the road. If I start them on a specific treatment, you got to look at the whole thing. Um, so I think for a lot is mainly trying to get full education of the base medicine. Um, that, let's face it, psychiatry, at least here in the States, it's a total of, if you count undergrad, it's a total of 12 years of
yeah,
studying. So you can't do that in 6 months.
absolutely.
You know what I mean?
And yeah, absolutely. I think there is a definite place to other types of clinician, but I wish there was kind of a system that everybody had its role within a care team, because
Yeah.
sometimes you have a lot of hands in the pot. I see it even here in Austria when we
Hmm.
have
Hmm.
we have universal coverage. You can have somebody doing psychotherapy for years for a pathology. I'm not talking about
Hmm.
just like I'm not feeling well today. Um,
Yeah.
and they have a psychiatrist, and those two individuals never spoke in their life.
Yeah.
This is something that really bothers me.
Yeah. That's what I'm trying to change.
I would love
um,
to hear more about your approach.
mhm, mhm. Yeah. So, I mean, it's as simple as, in the States too, a lot of people say we collaborate with other clinicians. But then when you go down to it, they really don't. I think our healthcare system is also right now in that tension. There's tension in the sense of like it needs to get restructured. And I'm a firm believer of learning from other industries. Maybe because I've worked in other industries where I'm like, okay, how is it that, for example, in the fashion industry, they have production done in such a way that it flows. Now you see big brands collaborating. You know how many people and hours that takes for that collection to come out?
Yeah,
So then when I look at the healthcare industry, I'm like, what are we doing wrong when it comes to our streamline of work? Right? How are we not collaborating at that level where I always say, start with, okay, the ego has to stay at the door.
yeah,
We're all experts. We all know something about something, right? So that's something that whether it's psychiatry, endocrinology, you know, full person medicine, whatever. We got to come together and work on these cases. The big problem is the lack of time that our healthcare system doesn't allow clinicians to do anything. The other day, I saw a post. It's a physician that he's trying to change our healthcare system, and he talks about how doctors today, and it's true, they're burned out. They have so much paperwork, and they're being drowned in paperwork. Um, and in the bottom of the thing, it said, this was not the reason why we went to help people.
yeah.
This is not the reason why we decided to go to medical school, to be filling out forms and
Yeah.
paperwork the entire day. We want to spend time with our patients, but our healthcare system really prevents that from happening. And unfortunately, what happens is the doctor gets pointed at like if it's our fault.
Yeah. Yeah.
Like, oh, my doctor didn't spend time with me. Yeah, because he had to go fill out 50 prior authorizations to approve all your treatments. So that needs to change. How there's many different things that could occur, but one of the first things that I always say is to look at other industries. How are they streamlining their processes to keep the designer designing and not worry about all the other paperwork, right? Because if I put, you know, any designer to start filling out all the forms to get them get things shipped, get things
Yeah.
sent to the customer, then they're not designing. It's the same
Right.
thing that's happening in medicine. So, I hear a lot of and mainly in social media, right? A lot of negative talk against doctors, like if we are these evil people that don't want to spend time with you. Listen, we went to medical school for so many years to spend time with you, to
Exactly.
help you, to treat you, but the healthcare system has not allowed it to occur, you know? So one of the reasons why I don't accept health insurance is because I saw that happening to me at a very young age when I started medicine. I'm like, wait, I just spent 45 minutes trying to get this medication approved by your insurance when I could have paid those 45 minutes spending with you,
Yeah.
you know? So it's distorted. It needs to change. And I just think even working together at a bigger scale, I mean, doctors tend to be smart people, right?
Absolutely.
At a bigger scale, we need to be able to get together and change that. How? I think it only works with working together.
I definitely agree. And I just gave a TEDx talk exactly about that. I was
Hmm.
talking about like the role of AI in healthcare and how we're looking at it in the wrong kind of lens, that we're
Hmm.
thinking it's going to replace doctor instead of providing the doctors
The
the,
tools.
the tools, and
Hmm.
finally kind of discharge them from being a bureaucrat, or instead of
Hmm.
sitting with a patient and doing clinical work. I think that when you look at um, streamlining work and you look at other industries, and it's so beautiful that you bring your experience. And every time I meet doctors that had other career before, there is something so special about them, and because they bring something different into medicine, a different perspective
Hmm.
and view. I think that when you look at healthcare, it's maybe the only industry that kind of doesn't care about the user of the system eventually. And the
Hmm.
users, by
Hmm.
the way, it's both clinicians and
Hmm. Hmm.
patients. But when in every other industry there is a product eventually, or there is a client, or there is a
Hmm.
customer, it's all done differently. And here, the feeling is that just like education, that is
Hmm.
also failing everywhere you
Yeah.
look. It was designed in different eras to
Yeah.
provide for different needs,
Hmm.
basically.
Yeah. And I'm glad you bring up that point because the same thing happens to teachers. I was a teacher for a little while and I noticed the stress and the burden that was placed on the teacher. That
Yeah,
it's like, okay, wait, they went into teaching to teach. But I'm
right.
glad you bring up how those were designed at a different time. And I think they got stuck there. They got stuck there in how we do our workflow for sure. And it also got stuck there in how we examine and how we do things, which is why, I look at brain imaging as such a important tool for a psychiatrist to get rid of the endless hours of time of trying to figuring out what is going on with this brain. Well, I can see it. I can see what the brain is doing or not doing that is causing you problems, right? So, I think using technologies like SpecScan, and there's a lot more to come, and I'm very excited about that. I think SpecScan and what Dr. Amen has been doing, even though it's a lot of work and it's been about 40 years of his career, I think it's just the tip of the glacier. I think it's just the tip. I think there's a lot more, and like in any specialty, psychiatrists has always been known to be a little bit out of the not following the norm. That's usually
Yeah,
the what attracts us into mental health, right? Those of us, like the psychiatrist, we never went into the other specialties mainly because they were considered like normal or expected. So I always say if we take this ability of our brains, then we should be able to transform our old, very old way of diagnosing and start using other modalities that other specialties have always been able to do without questioning it. You know, when the EKG came out, everyone was like, "What?" But it was immediately put into use.
Yeah,
You know,
right.
when the same thing with the CT and the MRI, right? These were things that popped up in this century. This is not,
Right.
you know, old. It's very new if you look at medicine, right? Um, and psychiatry has stayed with a book of checklists that we all know this is the most complex organ that exists. It can't just be diagnosed by checklists. And this is why when I get a patient, they've been diagnosed with like 5, 6 diagnoses. And you're like, okay, this is PTSD. Very easy. I can smell
Yeah.
it from a mile away. This is PTSD. So therefore, for all these years, they've been misdiagnosed and not treated correctly. Because when someone has something like a trauma block, it's really hard from an assessment, meaning the psychiatric assessment and talking to the person, to really pull it out. And I see PTSD as a Pandora's box. And I know we deviated a little bit of the conversation, but I think it brings an example of how we are practicing today that it needs to be revolutionized. It needs to completely change. And the only way to do that is if, you know, psychiatrists come together and put their heads together. I mean, that's how the DSM-5 started, right? They wanted to, at that time, figuring out what is going on. Let's start categorizing. But that's the system that was okay back then,
Yeah.
you know,
It
and
was.
let's look at even the history of the DSM-5. How many times has a diagnosis been eliminated just because it's no longer socially a
Yeah. Right.
pathology,
Yeah.
you know? So it's time to completely change that, in my opinion.
I think it's the only specialty in medicine that doesn't have, for the most part, clear biomarkers and imaging
Yeah,
that you
huh?
can,
Yeah.
and and like
It does
maybe
now, but
it does
very
now.
few of us use it because we're
And
not educated that way. Does that make sense?
yeah, and this is what drew me to your work, because you're looking at psychiatry not again as a kind of an art form that, okay, I've seen enough patient to know this is the
Right,
diagnosis,
right.
but you also use state of the art tools. Can you tell us a bit more about spec scan
Mhm.
and other tools that you're using?
Yeah. So SPECT scan, I learned it through Dr. Daniel Amen when I used to work with him. And basically is a blood flow study. It used to be used in cardiology. And what he did is he just moved it and like, let's use it in psychiatry because we can start seeing brain activity, right? Blood flow. When we see increased blood flow in these parts of the brain, well, that's telling us there's a lot more activity going on in that specific region. So if I know as the psychiatrist what that region does and is having more activity, chances are that part is working too much to do its function.
Mm-hmm.
And then what the SPECT scan is going to reveal to us is all these areas are going to light up on the scan. SPECT scans are, I think, not only changed for me the way that I practice psychiatry, but it's given me a whole broader approach of looking at the entire human being because now we also start seeing patterns that light up on the person. And there's a pattern that we were identified. It's called the diamond pattern because it's in the shape of a little diamond, and that tells us psychological trauma. Well, there's
Mm.
another pattern that I've seen that it includes the occipital lobe and it looks more like a triangle. And that tells me trauma that the person saw or that they experienced. So not just psychological, right? So a lot of my patients have both of those patterns. Now, these are patterns that I've been able to identify because I've been doing it for a little while. But when you start now looking at other patterns and then using other imaging to see what this brain is doing, then we'll be able to, my hope in my lifetime is to unlock some of those trauma blocks that people do. Again, it's because I specialize in trauma. So I tend to focus on that. But imagine all the other pathologies that occur in the brain that you can diagnose by looking at an image. I mean, cardiologists use a whole bunch of different modalities to diagnose heart failure, right? Endocrinologists do the same. Now, I also draw a lot of blood work. My patients, I've been called vampire. But I'm like, well, I need to know what your brain is producing or overproducing, because that tells me, okay, that for sure matches your image of this part of being overworked. Because I order this biomarker and it's telling me that this part. So, it creates a much better picture, even for us as psychiatrists. I don't like to use the word guessing, because let me tell you, there's no psychiatrist that is guessing. We are evaluating the patient. And at this point, we can't turn it off anymore. Every person that's in front of us, we're always like, what could be going on, right? We eliminate that. We eliminate human error, because let's face it, that also happens with the DSM-5, right? So if I eliminate human error, I get more precise results. I mean, in science, that's one of the biggest things we try to eliminate is human error.
Right.
But for hundreds of years, we've never used other things than the human, meaning the psychiatrist. So if I have a psychiatrist in Dubai and a psychiatrist in Mexico, chances are they're going to be trained very similar and they're going to have the same DSM-5 lens on, right? But this one might put this person on this treatment, and this one might put this person on this completely treatment, because they have cultural differences. But we all know that things like trauma, there's no cultural difference. The brain is the same. Our brains respond to stress and trauma exactly the same. Doesn't matter where we're from. So if we know that, imagine these two individuals, how they're treating their trauma patient very differently. So how do we eliminate that error? We need tools. We need tools to diagnose people correctly. So SPECT scan for me is one of those tools. It's not the only one, but it's definitely one of the tools that I hope we start using it, just like we use an EKG to look for cardiac activity.
I can't wait for this day. I'm working a lot about breaking stigmas in mental health, and it's very hard to see fellow patients that are kind of dropping off, from treatment because they feel it's guesswork. Like it's just trial and error. So I think it's about time that we are focusing this amazing efforts we have, and I want to kind of take this and maybe challenge you, because on the one hand, you are talking about making psychiatry more clinical. And on the other hand, you're working with soul and theology. And this is very interesting to me.
Yeah. Well, that's the clinical part is one part, and that's the part that I say superficial, right? Like any other clinician. But then based on our conversation, now you understand there's still a big chunk of clinicians that don't do that either. So imagine how superficial they are. So what I'm trying to change is also understand that this organ has emotions, records memories, records the feeling of that memory, also records the sensation, and maybe the word's not sensation, but let's use the word feeling again, the feeling of hope and peace. That's not very clinical, or at least been trained to be clinical. I think those are clinical markers of people improving, right? If you're feeling peace and joy, that's hard to, at least right now, that's hard to touch, right? To say, oh, there's joy, right? Or this is an indicator that this person has hope. We got to dive in deeper, meaning I got to take off my white coat, grab you by the hand, and go down that dark alley of that memory that was really scary to you, and go down there with you, so I can understand your pain. I don't have to go through the same pain. I think that's another misconception that, I have some patients tell me, well, that doctor just didn't understand what I went through because he did not go through it. Well, that's a fact. There's absolutely no way for this person to go through it as well. Because then imagine how many traumas do I have to go through to really understand my patient? Just like I don't have to have ovaries or a uterus to deliver a baby.
Right.
No, right? But with psychiatry, you do have to have a deeper connection with your patient for them to feel that you are feeling the same as them, and you empathize with them. But as a psychiatrist, they need to be able to do both the clinical part, but then also the soul part. And that's the part that I try to do with every single one of my patients. And I start with treating them as my family member. If you were my brother, what would I do? I would do anything to get you to feel better. And if that means I got to bring down my guard and share my difficulties and the things so you can understand me and we can have a good connection, then so be it. Because at the end of the day, I want you to get better and not spend years. I want you to feel better much faster. Does that make sense? So the soul part, the deeper part, as clinicians, we got to start taking off our layers of not appearing vulnerable. You know, psychiatry and the brain, we bring down our guard. We start feeling better when we feel that the person that's in front of us is actually connecting with me and I'm with them. And in my experience, that's been the best way to do that. I mean, and lately now that I've been doing more podcasts, I've been giving away this secret. And the secret is I have a closet here in my office with different shirts. And I literally change my shirt, change my clothes of who I'm meeting with. Because at the end of the day, I want you to feel connected with me because I want to help you. And I'm willing to do anything, even if it means I got to change what I'm looking like. One day I showed up to the clinic. That day it was an in-person day, but I looked at my roster and it was all young. Most of them were young girls. I'm like, okay, today we're wearing our Barbie shirt. So I have a Barbie shirt and I went with my Barbie shirt. I wore my combat boots, ripped jeans. And for one of the girls I had in my office, because I have a bunch of stuff in my office, I spray paint my hair pink.
This is incredible. I've never heard of a doctor doing this.
What did I do? I connected with her. And, you know, that was our first meeting. We were going over her brain scans, which is scary to go over because you're about to get this news, right? I gotta make her feel comfortable. And I'm willing to do, I'm telling you, anything to make sure my patient feels comfortable and feels that I care for them and I'm connecting with them. Well, we were leaving. The mom said, "You're the only doctor that she's spoken to."
Wow.
And I'm like, awesome. Great. You know, it worked. All this effort that I put in. So I think as clinicians, especially those of us that are psychiatrists and are working with people in a hurting soul, you got to go in there and get dirty with them. If they look dirty, you better look dirty too. Right. And what I mean by that is like if they have something that you're like, maybe she's, you know, I also had looked at her picture before. I was like, let me see how I connect with her. Especially that she was having a lot of history of self-mutilation. She was cutting herself, multiple suicide attempts. If I care to change the trajectory of her life, I don't care, man. I'll spray my hair any color she wants me to because I don't want her to kill herself. Does that make sense? Because if that was my daughter, I would do anything. So it has to start with that. And unfortunately, in medicine, we're taught the complete opposite. Don't connect with the patient. The patient-physician relationship needs to be close but distant. Don't let them get to know you. Don't, you know, I threw that out the window. You know, when I was in training, I was like, yeah, sure, that's what we would do.
Yeah.
But then I'm like, no, because this is a soul that is hurting and they need to feel that someone understands them and they need to feel that they're connecting with you. So all I did there was apply what I learned from being a fashion photographer. We know that I can dress. At that time, I had a muse. And if I changed the way she looked, she gave me a different look and a different feeling depending on the photo shoot. That's all I did. Copy and paste. Because we want to connect to the person. I mean, look at every single advertising company. That's what they do. Try to connect with the end user. And I'm glad you used that word. I'm going to start using that word. I'm going to copy you on that.
I'm a startup founder, so.
There you go. So that to me is vital in what I do. And yes, that's not clinical. Can it be trained and taught? Of course. When I work with my medical students and international graduates that are trying to match in the US for residency, that's what I do. I'm like, you know, if you feel uncomfortable about talking about any topic with anybody, then you got to work on that.
Yeah.
You know, or just say, you know what, this is not the person for me, right? If I have a lot of patients struggling with sex addictions. So if you don't feel comfortable talking about sexuality, porn, anything that goes in someone's mind who's dealing with that person might not be for you. it's okay. Refer them to someone else it is.
Mhm.
But if you're like, I want to help this person because that was my brother, I will do anything. Your feelings of uncomfortableness have to stay outside. So you got to train yourself to be a chameleon so that person can feel connected with you. And let me tell you, it works